Awesome. All right, we are going to give everyone just a minute or so to log on since we are approaching 8 o'clock here. And while we're letting everyone into the webinar, I just want to go ahead and go through some housekeeping stuff and introductions. To kick things off, I'll introduce myself. My name is Brooke. I'm a speech pathologist here at Tim's Medical, and I am really excited and honored to have Dr. McGrattan here with us this evening to provide her expertise and presentation. This webinar is eligible for zero point 0.1 ASHA CEUs or 1 PDH. If you would like ASHA CEUs for this presentation, we do ask that you stay for the entire duration of the session and that you complete a brief survey. The survey link will be posted in the chat, and then it will also be sent out to you via Zoom emails. It'll be sent out tonight and then a couple of days away from the end of this course, just to give you a reminder about the survey. And then if you'd like a certificate of completion, we just ask that you send us an email at tims-univ@tims.com. And we do want to note that sometimes the responses to that email can take up to 7 days. So just know that we will definitely get back to you within a 7-day time period. And then last but certainly not least, this webinar is being recorded and the replay will be put on the TIMS website, which again, I'll link in the chat and it'll be sent out via email. And then Dr. McGrattan has kindly provided a PDF for download, which will also be linked there. So if you have questions throughout the duration of the session this evening, we ask that you, if you can, put them in the Q&A section. But if not, feel free to pop them in the chat and we will try to address as many as we can during the Q&A portion of this webinar. And with that, I'm going to hand the floor over to Dr. McGrattan.
Great. Thank you so much. I really appreciate it. I appreciate the invite and just scrolling through some names of people here. It's good to see some familiar names and new ones. So those of you who I haven't met, I'm Katlyn McGrattan. I do all clinical research teaching in pediatric feeding and swallowing. And so, yeah, without further ado, I'll get started. I'm going to go ahead and share my screen with y'all. All right. And please, let's just see. Hold on a second. Here we go. All right. So let me know if that isn't sharing the way that you should be able to see it. Somebody can just chat, type into the chat. Otherwise, I'm going to assume you can see okay. So, yeah, the title of this talk is Normal Infant Feeding, a Landscape Plagued with Physiologic Imperfections and Caregiver Concerns. And I don't know anyone else that gives talks. As I pulled up what I said I was going to talk about in preparing this, I was like, man, I was feeling kind of dramatic, I guess, when I made this slide, this title. But I honestly think it's pretty spot on for kind of what we're seeing. Many of you can probably appreciate clinically, but if you've had your own children, maybe what you have felt on your end. And so what I'm really excited to do is talk a little bit about the data that we have to kind of support some of these concepts. And I think like the Cliff Notes version of what I'm going to say is, babies are not perfect feeders when they're born. And, I think we need to know a lot more. We have just enough to know that they're not perfect, but not enough to really make big clinical moves based on it. And so let's talk a little bit about that today. If you have questions, comments, please put them in the chat. And, as things are going, I'll address those as we go. So. Okay, so I am a very like black and white person, I guess for lack of better words, like gray areas, and I just don't drive well. Like I just need more clear cut points, which is ironic that I ended up in this field that is like so gray area for so much of it, right? And really the desire to bring order to something that didn't feel like it had a lot of order to me clinically to start out is why I pursued a research career versus clinical. I really love seeing patients, and that brings me a lot of joy. But just that desire to make more sense of things, I even to this day still have a lot of questions clinically for. And so one of the main questions I remember when I first started my PhD, I was working clinically. I was doing my CF. Um, and so much of the stuff, we'd get consults. I was young, as many new clinicians are at the time. I didn't have my own kids. I had babysat, but I had really never paid much attention to how they were feeding when they were feeding, right? That's not really what you do at that stage of life. And I remember a lot of individuals would be referring their babies, whether it was a baby in the NICU or a baby in the well baby nursery. Like this baby seems like they have a problem. And those ones were the ones that actually scared me the most because they're like, what does this baby have a problem? And I was like, well, I don't even know what normal is, right? And so that was kind of my conclusion at the time is we don't really understand what normal is. There's not a lot of data to help us clinically guide, like, does this child have a problem versus not? But just thinking conceptually, like how in the field of like medicine do we differentiate what is normal from impaired, right? It's a kind of foundational question that when I started doing research into this, like I was like, I feel like I should know the answer to this, but I don't. And the more I dug in, the more I realized it's because it's not a straightforward answer. So there's two primary, I guess you could say, ways that you could delineate normal or impaired. And this is not exhaustive, certainly. But the one on the left you can see is based on like physiology and just statistics. Okay. So here you can see a normal curve. And so, say I'll give it just an example. We can do it based on physiology, symptoms, anything like that. But in this example, I give that, a baby's referred to you and they are coughing with fees. And you say, well, is this normal or is this indicating this baby has a problem, right? Well, if there is data to support this, that you could say, well, coughing occurred in 1% of individuals, therefore it's abnormal, right? If you gathered a whole sample of healthy babies and only 1% of them coughed during feeds, then that would make you think this is an abnormal thing. And why would we come to that conclusion? Well, just based on the normal curve, one of the main cut points is if we say less, if 95% of babies are doing something, this is babies for this example, then anything less than that would be abnormal. Now, when I first was reading about this, I was like, well, that doesn't make sense because for like the growth chart, for example, right? When we look at newborn or baby growth charts or weight trajectories and things like that, they don't base if you have like poor weight gain on if you're like less, higher or lower by, 5%. They are more conservative than that. And the reason they do that is because they know that they want to be able to have time to intervene, and that intervene process is going to take a certain amount of time. And so that's why, kind of on the background, clinically, they do sometimes change these percentiles based on what clinically matters. So that's one side of things. On the other side of things, you have delineating if something is normal versus impaired on if it's prohibiting an infant, for this example, of meeting functional feeding outcomes, right? So a weight gain, age appropriate weight gain with respiratory health. And this last one, which I'll talk about more, for lack of better words, I put just like enjoyable, like low stress experience, right? Can you be doing those other two and then feeding is a complete nightmare? So I think kind of these three things. So in the example before, when we're looking at, coughing, it could be, well, a baby's referred for coughing, but their weight gain is fine, their respiration is fine, and it's not really causing stress for the baby or the feeder, and therefore we're going to say that's normal. Or, if there were studies done that look at coughing and say, well, actually, babies who cough during feeds are more likely to end up getting an aspiration pneumonia in a year, say, then we would identify this as abnormal because it will prohibit future function. So this is sort of the framework that I'm going to use to talk about some of the research findings that we've done to date, and then kind of use a case to tie it all together, if that works for you. Okay. So just starting out, looking at physiology. So what I'm going to do here is I'm going to play this video of this baby eating, and you can kind of make your observations from it. And the main question is, say this baby was referred to you for an evaluation. Is this normal or is this an impairment, right? And really this determines like where you're going. Like, are you going to be going to do a swallow study or are we going to thicken feeds? Just giving examples here. So here is the video. Let me know if you cannot hear it and I can mess around with my sharing settings. So this is just like a little segment of a feed. This is a baby that is 3 weeks old. But just to kind of highlight some of the things that we're seeing at 3 weeks, we, hear this high pitch, like kind of yelping sound that many of us would call stridor, loud breathing overall. There's loss of milk. I don't know that you could see it in this little clip, but a significant amount of milk loss where they would feed the baby with like a burp cloth under his chin. Stress cues, that's like a really big thing, I think, of the last few years. And so you can see in this baby what are often considered cues for infants. Like here we go, hands splaying and kind of pushing away and arching their back, things like that. This baby would often fall asleep before feeds were completed, coughing and choking regularly, and shallow, irregular breathing. Now, you can hear that here is kind of just kind of gulping in air between things, not this really coordinated, like calming feed that maybe many of us think of when we're thinking of a bottle feed for a child that doesn't have problems. So if this baby came into your clinic, right, that's my question. What are your conclusions, right? Is this normal or is this impaired? And to me, this is just so fundamental to our entire field. What we're doing, we're spending time looking at treatments and all this other stuff, but like really knowing if we're treating something that should be treated or not is pretty cornerstone foundational to that. And so we've done a few studies really with this question in mind, because like I said, these are the types of kids that I would get consulted on, whether it was like in the well baby nursery or just as an outpatient where the parent had concerns that I really wasn't sure of the right answer. Okay. And so the first study I want to talk to you about, this was on healthy term babies. So to be included in the study, parents had to answer certain questions that would indicate that at that time the baby was not having any feeding issues. Weight gain was fine, respiratory health was fine. They didn't perceive that their baby had any type of feeding problem. And what we did is we had caregivers. This was during COVID, which oddly aligned, this design was already happening before COVID happened. So it kind of was a happy accident. But we had parents monitor their babies for 48 hours every week from birth to 6 months old. And they would feed their babies as they typically would, typical nipple, typical environment, feeder time, all of that. And they would just log everything and they would share it with us. And in addition to logging like the standard things like how much they drank, all of that, they would fill out a survey at the end of each week, indicating any types of symptoms or feelings they had towards their baby's feeding, as well as how frequently their baby coughed during a feed. And I use this because that at the time was like the thing that I had always been taught, when you do a clinical eval looking at adults or infants, they say, look for signs of aspiration. What's the number one sign we're looking for? Right, coughing. And so I had always assumed if a baby's coughing, then that's indicating they're likely aspirating. And this is problematic and probably indicates there's an impairment. So the data I'll be presenting here is from 61 infants. This was just the first month of life. So looking at every week over that first month of life. And so looking at this in the context of as we're examining physiology, we can see here, this is looking at, let me move my little icon here. There we go. This table, I kind of tried to simplify a lot of the answers that we had on these standard questionnaires to what was like the most clinically digestible method of doing that. And so the parent report, we had them fill out the infant and child feeding questionnaire and looking at parent responses throughout the first month of life. If we're using that like 5% rule outside of 5% is normal, we found that all of these things that I would say I was trained that were often indicators of problems are actually normal. So baby turning their head away from the bottle, arching their body, occurred in 14% of babies. Choking and coughing, 12 to 24% of infants. Loud breathing during feeds, 28%, and falling asleep before the end of the feed, 38%. So again, I think these are certain metrics that we all kind of chart on and talk about, but just further questioning, like, one, we need more research on them, but two, if they're not necessarily indicating impairment, in this definition of impairment, then why are we talking about them, right? And I think, or maybe we have to change the way we're talking about them. So this is, evaluated in a binary way, like, does the baby cough? Yes or no, ever, right? Maybe what would be a much different thing is if we quantified, how frequently that was happening or things like that, which I'll talk more about next. Things just based on that 5% rule that would be considered abnormal, a baby that's refusing to eat. or a baby that is gagging when they're being fed. So interestingly, of these, of the list of all of the items in this infant and child feeding questionnaire that would potentially indicate impairment, the only one that on their own strictly indicated, like from that percentage, was refusing to eat and gagging, um, which is quite interesting. We then looked at coughing specifically. Like I said, that one has always just stood out to me because it seems like across the lifespan, this is one that we generally think of as like this is indicating a problem. Maybe we should go and do an instrumental assessment, right? Um, and so, as you can see in the upper left, 93% of infants coughed at least once in a feed during the first month. So, in those 2, 4, 6, 8 days of monitoring, at some point, almost all of the babies coughed, right? Not saying that they coughed every single feed, but at some point they did. So, not overly surprising. We didn't find any significant change in the percent of feeds with a cough within the first 4 weeks of life. We actually are in the process of writing these results up because as I mentioned, we have 6 months of data for these, so we can look at that a little bit further. But again, this is important to keep in mind. These babies were just a month old, 0 to 4 weeks old. Um, when we look at how frequently coughing occurred, we found that infants coughed an average of 17% of feeds. So that was just about 2 feeds per day. But that wasn't, I mean, that's the average. And I think that's where looking at the counts is actually quite fascinating because some kids cough like almost every feed. And in terms of how frequently they coughed in a feed, most of the time it only was once. However, we had some babies that would cough like maximum of 6 times. I should note that these were bottle and breastfed babies. We found in this study we compared to, we found that babies were less likely to cough if they were breastfed. So then we did an additional study looking at this just more recently. Again, this was healthy term infants, but these babies were older. So we had an N of 30 for this sample. Infants were on average 4 months old. And we did one actual in-person feeding monitoring. So not relying just on caregiver report, but we went to the baby's house. We had the parent feed with the typical bottle nipple they used, typical environment, typical feeding time. And we evaluated and we video recorded the feeds and evaluated them with the early feeding skills assessment, which is, for those of you not familiar, one standardized clinical method of performing like a clinical swallow a valve, for lack of better words. So interesting. Again, I collapsed these scores. So those of you not as familiar with this assessment, it's a 3-point scale, indicating like an immature pattern versus mature on the high end of things. And looking at the results, however, we found that across like any percentage of the scale that these were normal findings. So some loss of milk from their mouth, any amount or frequency was normal in that scale range. Gurgling at some point during the feed, this high-pitched yelping kind of stridorous sound, coughing and choking during the feed was very commonly observed, and stress cues. So interesting, I think that using judgment and not force feeding infants is a very logical and smart thing to do, right? I think probably very few people would argue with that. But I think this finding of stress cues is really interesting because if you look at the definition of stress cues for this, in talking with the tool developers about this, we had a long conversation about like what does this mean? Because some of the stress cues are like blinks or hand splaying or different things like that. And I think also saying like some of these movements or some of these patterns might just be the baby's communication, right? Of like this is too much, and maybe it is some type of stress cue, but like it's a natural communication attempt that if the parent like listens to that, right, which we teach caregivers in the NICU specifically, to listen to those nonverbal communication methods, then all is great. So yeah, this was quite interesting as well. Looking at those findings that were abnormal, again, keeping in mind that these babies were on average older, right, than the ones in the last study that I just talked about. So when we looked at the clinical evaluation that was abnormal, we found that less than 5% of the infants in our sample had some instances of shallow or irregular respiratory swallow coordination. I'm kind of summarizing the titles of these things to make it more clinically relevant if you're not familiar, but just reading patterns. Some labored breathing was not considered normal as far as this study, never opening their mouth to the nipple or never starting to suck on the nipple in their mouth. Some occasions of not opening their mouth was normal, but if they just never did for the full thing, that was not normal. Loss of tone or color change, which I think many of us would probably intuitively agree, like that seems very abnormal if that ever happens. No, it doesn't matter the frequency of that. So, I say this, both of these, I mean, specifically this one, this is an N of 30, so certainly on the smaller side. And when we're talking about developing like what's normal, we're talking about hundreds and thousands of data points. If you think about how much data went into the normal, like World Health Organization curves of growth and things like that, were this huge sample. So, I think that's where standardizing how we're looking at things and using similar outcomes is really important because it's through these big types of data that we're really going to better understand this. But I think nonetheless, this is compelling that is starting to kind of similarities you can see across both of these studies and potentially some differences strictly as a result of differences in age, which one would likely expect that a baby that was, less than a month old would likely feed with a less mature pattern than a baby that was 4 months old or something like that. Okay, so, just kind of circling back and going back to this case example before, you get consulted on this baby and is it normal? Is it not? I'll stop this. We watched this before. But these symptoms or these indicators essentially that we saw based on the data that we have so far, indicates that these actually aren't necessarily in themselves an indicator of impairment, right? Like all these things that this baby were doing don't necessarily indicate that there is a problem based on the data. The one that I would say would potentially indicate this is this shallow, irregular breathing based on that last data set that I just presented. But again, keeping in mind this baby is 3 weeks old, and that was the data set that was from babies that were 4 months. We didn't look at that outcome in this one. So again, just reiterating, like I'm not saying make huge changes in your clinical practice around this, but I think it's always important to look at the whole systemic health, the whole human, whatever age it is across the lifespan. And I think this data really speaks to that, is that one specific thing isn't what we should be making big clinical decisions on all the time. So what I want to talk about kind of next is some study results that we have. They're just like just hot off the press. We just started analyzing this for this talk. We have a lot more data to collect as part of this, but I thought it would be interesting to bring this in. Um, so, we're looking at what normal is. And the tricky thing with infant feeding is that it's going to be, I mean, there's plenty of evidence in at-risk populations that there's variables that are going to influence how that baby feeds, right? So breastfeeding, right? The mom's letdown, for example, that could completely change how that baby feeds, and that's an influence of that mom, right? Or in the case of what I'll be talking about now, when we're looking at bottle nipple flow rate, what flow rate you're feeding the baby probably is going to change how they perform and what normal is for that different age. And so for those of you who are a little bit less familiar with this, generally speaking, across bottle companies, whoever the company may be, it's pretty similar, is that they're generally advising nipple selection that's guided by age and feeding performance. So this kind of like hybrid approach where they label the bottle nipples oftentimes based on an age, but then saying, well, determine if your baby's appropriate for this. Look at some of these indicators of performance. And so you can see these here. So longer time to finish a bottle might indicate they need a faster flow rate. If they're fussy or irritated, falling asleep during a feed, again, all indicating potentially needing a faster flow rate versus gulping, hard swallowing, coughing, choking, milk dripping, refusal, indicating potentially they need a slower flow rate. So this is the information that we provide parents and say, okay, figure out what is the best nipple flow for your baby, which based on the slides that I just presented probably is even more, eye-opening of like, well, I don't know what do we make of all of this. And so, I was really interested in this, how do parents feel about selecting bottle nipples? I think Brittany Kregler mentioned this. She's like, I didn't even know that you changed bottle nipples, and I'm in this field until she had babies. I was like, it's a great point, like I think a lot of times if you're in pediatrics, you take some of this stuff for granted, but many of the parents have no clue about any of this stuff, and understandably. And so, how are parents making these decisions and how do they feel about it? How confident do they feel in these decisions? So, what we did is we have a study going on. There's multiple arms of the study. But for the one that I'll be talking with you about today, we took healthy term infants, again, without any current feeding problems. And we started out and we asked them some questions on overall their confidence in their bottle nipple selection for their baby, how they were selecting that bottle nipple for their baby. And then we had them do 3 bottle feeds in their home environment. One of them was using their typical regular flow nipple. One was one flow rate slower, and one was one flow rate faster. For this, we used Dr. Brown's bottle nipples just because they were in alignment with the instrumentation that we were using with that. And so we wanted to really standardize across because, as many of you are familiar, different bottle companies have different flow rate nipples based on the labeling. And so we really wanted to be able to control for that. And then after we had parents evaluate the appropriateness of the flow for the bottle. And again, throughout these feeds, parents were blind to the flow rate. The label of the bottle nipple was not written on the side of the nipple, so they weren't aware which one their baby was being fed with. So at the time I pulled this data, we had 26 infants that were on average 4 months old during these feeds. All of the bottle feeds, I should mention, were completed within 1 week of each other to control for maturation, and they were all randomized in order. So I think the main conclusion I have from this initial data is that parents have a lot of uncertainty regarding nipple selection, to no surprise, right? 95% of parents used feeding performance as a primary guide for nipple selection. I actually was really surprised by this. I assumed the majority of parents would use like the flow rate, like ages. It just seemed to me that was like the most intuitive, but I'm sure they were using that in part, but generally speaking, they were making modifications based on their perception on how their baby was performing. But only 20% were confident in their ability to accurately select which nipple to use. Okay, so they were using this, but and when you asked in a binary question, do you think your baby's feeding on the right nipple? Almost all of the parents said yes. But then when you said, how confident are you in this answer? They're like, not super confident at all. And it turns out they were spot on in their abilities. So we looked at the accuracy and like I said, we were feeding with these different ones, and then we asked, is this slower, normal, or faster? And they would have probably been better off if they could just flip like a three-sided coin in their selection. They had really low accuracy, 17 to 27% accuracy in their identification of flow. So looking specifically at sensitivity, you can see 0.17 for slow and normal. They were slightly more accurate with the faster flow, but still not overly impressive. And when we had them rate it, we asked them to indicate what symptom was making them say, that this was slower or normal or faster. And the most commonly reported ones were the baby was taking longer to finish the bottle. They were fussy or irritated. They were gulping or milk was dripping, which is really, really interesting. So, you know, the last question in the survey was strictly, do you feel like needed to be a more clear-cut way to determine the optimal nipple for your baby? And 77% said yes. Interestingly, we did a lot of qualitative interviews with parents, and there was so much different feedback that varied from parent to parent to parent. But the one standard reporting thing that parents were saying is like, I would love a more clear-cut way because I'm constantly wondering, like, is my baby normal? Like, is this normal, right? And any of us who have kids, we question that regularly. Like, are other kids not sleeping through the night? Like, this is currently my home situation. Is anyone else, three children, never sleeping at night? But yeah, like we're always wondering what normal is, and the internet's great and has a lot of information, but unfortunately, it's what you put in is what you get out, and they're just giving symptoms in, so they're not getting let out. So I think this just speaks to like especially for first-time parents, we hand them over this baby and say, here you go, figure it out. But it's not intuitive all of the time, and especially with the different options available for consumers, there's a lot of uncertainty in how parents move forward. All right. So that being said, I will kind of pivot at this point and say, we've talked so far about like clinical presentations and that like a lot of these things that many of us think are indicators of impairment, typically, I think these are typically coming up when we're talking about aspiration with full understanding that there's so much more to swallowing than just aspiration, right? But that's one of the big things we hear. What does this mean for aspiration, right? If all of these kids are coughing with feeds, right? That certainly doesn't indicate it's aspiration. It could be like reflux. It could be many different things. But it's kind of a logical, like A to B kind of conclusion to come to. So what do we know about like normal swallowing physiology? Well, starting point, I think in pediatrics, we start out and look at what they've done in adults because most of the times we don't have the answers in pediatrics. And there are a lot of studies looking at what is normal swallowing biomechanics in adults, right? So many that I couldn't even fit them all on one slide. When I look at infants, right, then I have this one slide that can showcase this beautiful, really, really old paper that I absolutely adore. This, like, I don't know, this probably speaks to my cool level, but like, there's certain people that I'm like, if I could go back in time and meet one person, right, he would be like at the top of my list. Dr. Arch would be at the top. So this is a study from back in 1958. It was one of the first studies to look at swallowing under fluoroscopy. And at this point, it was just like the method was getting, first developed and really just describing it. This was like when study manuscripts weren't necessarily the way they are now. And so it actually ends up being like a beautiful story. And in it, he describes that as the bolus moves downward, the posterior wall of the pharynx was brought forward, displacing soft palate towards dorsal surface of the tongue, yada yada. They didn't have baby VFSS IMP at the time, right? Even if they did, we probably wouldn't have been able to even do it reliably based on the image quality we can see in this upper left. So it was certainly not like a Tim's. Tim's didn't actually say that, but that's just a line. So there you go, Tony. This wasn't like a Tim's high def, fluoro image that we're used to now. So we weren't able to make things like this percentage of babies had a collection of residue or this percentage of babies aspirated or things like that. But what we do have, this sample was of 35, but otherwise, as far as we can tell, healthy, non-dysphagic infants that were between 1 hour and 6 months old. Floor studies were run at 25 pulses per second, and they visualized 8 seconds of the feed, so very, very short segment. So some of the things that I found interesting from reading this is that they report that in these otherwise healthy kids that food passed down the sides of the larynx while the lumen was still open. So to me, I'm interpreting that as there was like an initiation below the level of the vallecula. Exactly where, hard to say. And this sort of tracks with what we have seen from adult literature, where 67% of healthy adults initiate a swallow below the vallecula if they're having sequential swallows, right? As Daniels has done a study on. And we know that when babies are bottle feeding, they're doing all sequential swallows. So this does track, and again, this we don't know if initiation in the pure forms is in fact normal from this, but it would seem likely to me that it wouldn't be surprising. I guess I would put it that way. So much to the point where when I'm doing my charting, I actually have tried to change how I phrase that. I don't put like a delayed initiation of swallow to the pure forms. I simply just describe what it is because I don't know how much weight I put in that as a binary outcome in itself. This is Dr. Guran's work with Dr. Martin Harrison team looking at healthy adults, MBS-IMP, 21 to 68 years old, where they did swallow studies. And again, if we're looking at just like the statistical definition of normal, generally speaking, like some penetration at some point doesn't necessarily seem to be an abnormal finding, maybe like a low, not a super common finding, but aspiration would in this case be abnormal, right? It was only observed in 2% of individuals. And then we have the great work from our friends in the Piglet Lab with Dr. German and Chris Merrow, who are fabulous scientists looking at swallowing from piglets. And so this is the closest study we actually have for human infants, which again, this is piglets to be very clear, but they found that all of the piglets were aspirating, and it typically occurred around 25% of swallows. Now, this is a small sample, and the goal of this study wasn't necessarily to talk about the prevalence of aspiration, but I think just indicating this interesting like difference between potentially what's happening in adult and infant. And I always, when talking about this, I think about like these age-related changes. And, if you had a child that at 1 year they just got up and started walking across the room with like totally normal gait, that would actually be abnormal, right? That would be creepy, but also like crazy abnormal. You don't expect a baby just to get up and walk the first time and not fall over. So to me, conceptually, it makes a lot of sense that some levels of imperfection, and I'm not saying necessarily aspiration, but it wouldn't surprise me if that was one of them, could be a normal variant in the early stages of life, and that with maturation, maybe we refine our system to be able to not do that as much. So, what we did, we had a much larger study going on, looking to develop a new non-invasive method of feeding assessments. And as part of this study, we were enrolling preterm infants that were typical feeders and growers. So otherwise would have not gotten a swallow study that wasn't part of their clinical care. It wasn't felt to be clinically indicated. It was done strictly for research. All families were underwent informed consent. We took that part very, very seriously, the ethical component of it. And so after talking through the study and the risks of the study, we had all parents had to fill out like a quiz to make sure that they actually knew everything they were signing up for. And so all of that said, we did swallow studies on these babies that wouldn't have typically gotten these swallow studies following a more abbreviated fluoroscopy protocol to keep radiation exposure lower. Um, we excluded infants that had high risk for swallowing problems, so prenatal drug exposures, syndromes, genetic anomalies, or any comorbidities not related to prematurity. So BPD, that would be included, but a baby with like hypoplastic left heart syndrome excluded. We then followed up these babies for 2 years, and any baby that ended up getting a feeding therapist referral, poor weight gain, respiratory morbidities that potentially could be associated with dysphagia, or needed alternative nutrition within that time period were excluded for the study. Knowing that we were probably excluding more kids than we needed to because not every respiratory problem is aspiration induced and it's hard to really show causality there. But what we wanted to make sure is for this set here that we are specifically saying like these are children that didn't have functional problems in the future. So our sample for this included 19 infants. The average age at the swallow study was about 37 weeks. And looking at overall, they were taking about 68% of their oral nutrition by mouth. Some of them were taking full oral intake. All of the infants had to have some indicator of swallowing problems. Now, whether or not that was enough to clinically warrant a swallow study is another story. So, apnea or bradycardia on occasion, some coughing with some of the infants, and the majority of the infants, the symptom was that they weren't taking enough oral nutrition. So we rated all of these swallow studies, every swallow using the baby VFSS IMP. And here are some of the key findings that we saw. The first was that nearly all infants initiated in the piriform sinuses at some point in the swallow study. So if we scored every swallow and then said what's like the worst score like for OI scoring that we have, we can see that 89% initiated their swallow in the piriform sinuses at some point. Interestingly, though, this wasn't the regular place that the swallow was initiating. It typically only occurred there on average 28% of swallows. So this is the type of thing that I'm actually really interested in knowing more about. To me, as we're getting more of this data and some other study results that I won't be reporting on today, but the more data that we have indicating that like all of these populations that I've looked at so far do initiate in the swallow, in the piriform sinuses at some point indicates that maybe that might, like in itself, may not be the most sensitive way to report. You can report it, but then for me, I'll put like an asterisk under it and I'll put like on average, this was 28% of swallows or something. And that's something that I'm just looking more into because maybe it's the percent of swallows that they do that that's a better indicator of like, children that end up having functional problems versus not. We then looked at the how this changed over time. So we looked at the Charleston protocol, looked at the first five swallows at 30 seconds, 1 minute, 30 seconds, and 2 minutes and 30 seconds. And we saw that swallow initiation in the piriforms increased as the feed progressed, as you can see here. And this was not associated with postmenstrual age or for full oral intake. We then looked at pedal pharyngeal approximation and tongue-based retraction. I'll start down with tongue-based retraction because it's pretty remarkable that all infants at some point had a score of narrow for tongue-based retraction. Here's the example of that here for some of you who may not be as familiar with MBS-IMP. I can go ahead and play that. So this is showing narrow tongue-based retraction. Try to pause it for you. There we go. Um, I say this was interesting for me. I work a lot in the neuromuscular space where we're doing like these swallow studies before we're starting to do different treatments like gene therapies and stuff, and we're wondering if some of these findings could potentially be surrogates for underlying deficits that occurred in utero. And so this finding specifically interests me because for a while I questioned is like narrow tongue-based retraction an indicator of that. Again, these were preemies, so it's hard to say maybe if they were term, they wouldn't have had this narrow tongue-based retraction. But it is also very possible that babies, it's very hard to get them to sit in just completely straight view. Like you can see, both sides of this baby's jaw. So I think the ability to pick up artifact from the other side can kind of result in some of these findings too. Palatal pharyngeal approximation. This will be no surprise to anyone working in the NICU that we saw 63% of infants had some level of escape of the bolus to the nasopharynx, likely, indicating some type of like coordination issue. Moving on to bolus airway entry, we see that the majority of infants exhibited penetration at some point in the swallow study. But generally, it was not frequent. So 74% of infants exhibited penetration, but it typically only occurred 16% of swallows. And the depth for the majority of those swallows where penetration was observed was above the level of the vocal folds. And this is just showing the change in penetration as the exam progressed. And we see there's a significant increase as the exam progressed as well. Again, this was not associated with PMA, full oral intake. This is a small sample, N of 19, so I wouldn't, the associations outside of just the changes in physiology, I would say it's kind of hard to control in those small samples. What's really interesting, though, is this change over time. In the first paper we ever did looking at swallowing changes over time in children with feeding problems, we saw that this, increase in frequency of penetration, for example, occurred. But there was no change between 1 minute, 30 seconds and 2 minutes and 30 seconds. I attributed that to dropout because a lot of the kids, like clinically, if you see that, okay, they're having deep penetration on every swallow, a lot of clinicians would then stop that presentation and try an intervention, anticipating things were going downhill. So in that initial study, I assumed that it was just a change in sample size, which is why we didn't see that change. This study, we had all babies continue the protocol no matter what the findings were. And interestingly, across the majority, almost all except for one outcome, there was no change between 1 minute 30 seconds and 2 minutes and 30 seconds. So what I find interesting as we move forward is like, is there, in infant swallow studies, we look at the first part because we don't know how long they're going to feed. So we don't want to look at the end of the feed where potentially we would see the worst performance because we don't know if we would actually get anything. But this kind of raises the question, this finding overall is like, do we see this like increase, things get worse, but then they actually maybe stabilize and kind of orient themselves and kind of balance out? I don't know. I'm interested in looking at that further, so I'll report back more. Moving on to aspiration. To be honest, I was expecting a lot of our babies to aspirate. I just expected it to happen because, again, some of these babies, I think the youngest baby we had that actually did the swallow study was 35 weeks. They had just turned 35 weeks, so they were very little still. And I wouldn't be surprised if that was happening, but I was not correct. We did see aspiration, but it was not common. 11% of infants aspirated. Um, and yeah, they kind of just varied in the differences. So we see gestational age, they were just barely preemie for one of them, and then the other one was 34 weeker. Both were just around term and taking almost all oral feeds. So, you know, before I move past that, what do we conclude from this? Well, again, a very clear thing is these are preterm babies. So I don't want to say like, well, because these preterm babies had these different findings, that's normal for a healthy term baby. That's certainly, I don't think we can extrapolate to that point. But I think this is the closest we have at this point to like what could be a variant of, the lower side of integrity that we would expect. So I think as we move forward, investigating this further is important. So to wrap things up, before we get to questions, I did want to talk about kind of switching things to function. So we've been really talking about like the statistical normal to so far, but let's talk about these functional outcomes of like, is the baby gaining weight okay? Are they in good respiratory health? Is feeding enjoyable or is it low stress? Um, this bottom one I'm really intrigued by. Um, I think I think it raises the question, and I don't know the answer to it, but it raises the question that we should look at is this realistic criteria for function when many aspects of infancy are not enjoyable or low stress, right? Like any of you who have had like a newborn, like there's plenty of parts that are not low stress or enjoyable. Love them to death, but like it can be a lot and it can be imperfect. And I think currently, like in this age, when you talk to people of like our grandparents' age, I think they probably were a lot more okay with that imperfect than we are now, where like we're not used to things being as hard in many ways, right? Healthcare, we can call somebody up on our phone and get a prescription right away. Like we have solutions for so many issues. I can ask chat an answer and it gives me a great response a lot of the time, right? So, I think it's questionable. Like sleep is a great example. Reflux, right? Reflux causes babies discomfort. It causes parents discomfort. It causes babies sleepless nights. It causes a lot of really stressful, not enjoyable things. But it is normal, right? This is a normal part of infancy. Like if you look at just from statistics standpoint, like a lot more than 5% of our babies are having reflux. Um, Colic, right? Which we don't necessarily even know what colic is, but like that same thing is like this is a common finding and maybe feeding could fit into this as sometimes feeding is imperfect, but that might be a variant of normal. And I'm not saying, I just want to be very, very clear. I'm not saying that if feeding is imperfect and there are strategies that are not going to cause more harm than good, that we shouldn't employ those, right? Great example of like maybe changing the flow rate, maybe pacing or things like that. There doesn't seem to be much harm that's coming from those. But I'm speaking to this more in the sense of like as we're thinking about like when we refer infants on for instrumental assessments or when we put them on thicken feeds, which certainly in some places they have a role. But keeping that in mind, if the baby is gaining weight and in good respiratory health, but feeding is stressful, keeping kind of all of this in mind. And I don't certainly have all the answers to it, but it's more of just kind of a dialogue here. I'm not sure about y'all in your practice. I think the other component of this is like that emotion is all relative, and I kind of touched upon it on like generational changes, but like I'm not sure if you noticed, but I know for me, most of the referrals I get of otherwise healthy babies in the outpatient setting that are getting referred for a clinical eval or an instrumental eval are typically first-time parents. It seems to be a trend, and I have not studied that. That's just completely anecdotal. So I'm curious if anyone else has had that experience. But like I can tell you, like from my firstborn, the things that I would call the pediatrician about are completely different than from my third, who I'm like, she'll figure it out. She's okay. So I think all of this, when things are really subjective, it's hard to use that as a delineation of when we're going to apply a more invasive like treatment or things like that. And that's why this research is really important, in my opinion. So going back to looking at function in terms of the studies I've presented so far, right? The first one, the term babies that we had parents cough counts and record symptoms, were they functional? Yes, both term studies, in order to be included in this study, they had to be functional. So despite these babies coughing, despite these babies spilling milk and all of these things that we talked about that fell in the category of normal, they were gaining weight fine and they were in good respiratory health. In terms of future function, we followed up with those babies for coughing for 1 year, and all of the babies that are reported on in the study were functional for 1 year for respiratory health and weight gain. In this smaller study of 30 term infants where we did the in-person assessments, we did not do long-term follow-up. So we don't know, maybe some of those babies did end up having future functional problems. So again, just highlighting the need for future longitudinal studies that are much, much, much bigger sample sizes to draw conclusions on. And then lastly, the preemies, right? So again, 11% of these preemies had aspiration and the majority of them had penetration. So were they current functional? No, right? They weren't currently functional. In order to be in the study, they could not be functional. But they weren't dysfunctional in the way we typically think of when a baby would get a swallow study. This was really, the impetus of this sub-analysis for me was that if we do a swallow study on a preemie and we have this finding, how do we even know that the finding we have of aspiration on the swallow study is the key thing causing the symptoms? Maybe every preemie would have had that finding. We just never had looked at it, right? So that was really the question I went in with. So generally, no, 68% of these babies were relying on a tube for nutrition. All did have some level of symptoms. A lot of them, I will say, were discharged within 48 hours of that swallow study. So that's just to kind of cater like how clinically functionally impaired that was. We do know sometimes discharge can be questionable as well. So there's that. But I think the important thing is all of those babies that were included, we did not make any recommendations to put them on thickened liquids because the swallow study wasn't clinically indicated. We would have never known about this if we didn't do the swallow study. We shared the results with the clinical team, which prior to doing the study, we had come to this agreement that we'll share with you these results in case some clinical problem where this information is important to know arises. But otherwise, their stand on this is we wouldn't have otherwise known. We're not changing the plan of care. So we're not going to put them on thickened liquids. So all of these babies continued on thin liquids, and we followed up with them for 2 years, and all of them were functional. None of them had, pneumonias, recurrent respiratory infections, or problems in weight gain as part of being in this study. So I think that's interesting too. Again, just speaking to the need to really take all of the pieces of the puzzle and put them together in making determinations about where we go from here. And just to kind of reiterate and underscore, looking at the healthy term infant studies, they filled out all these surveys, and one of the questions is based on these, reportings, do you have any concerns for how your baby's feeding? And 10% of the parents said yes. And as part of our IRB, like we said, if parents said yes to that, I would follow up with them to make sure that they had support that they needed. And in those cases, the parent said, I have concerns about everything about my baby. I don't feel the need for like a clinical veil based on that, but like everything I'm worried if they breathe the wrong way. So that's kind of what it fell into, is that parents, especially first-time parents, understandably just have a lot of anxiety of what is normal and if their baby is needing it or if they need supplemental help. So to close things out, we talked about physiology for this little friend. So we said that, everything except for maybe the shallow regular breathing, we didn't know how to interpret that. But are they functional? Yes, they are completely functional 5 years after. This is actually my son. He was a horrible feeder. And he's great eating, thriving, no respiratory issues ever, no problems with weight gain. So, I think the take-home point of all of this is, as we know, it's harder to do than we know, but it's a piece of the puzzle, all of these things, the physiology, the proportions, the functional impairments. The answer to this is really going to be getting more data on what normative is and how that differs from children who actually have clinically significant functional impairments to help guide us when we need to be more conservative or when we need to be more liberal, which is something I know I personally struggle with clinically regularly on, what is the line here, and I don't think we necessarily know it. So. With that said, I will stop sharing and I'll turn it over to questions. Beautiful. Okay. Okay. So the first question I see is finding common feeding behaviors incredibly. Okay. On your 6 month longitudinal follow-up, did any of these full-term healthy babies develop anything concerning? No. So all of those babies in the coughing study and that we reported, and I think there was one baby that ended up having something that we excluded them from. I think they ended up having some bigger issue, but oddly enough, they weren't one that had like the most coughing or anything like that. Like the ones that actually were coughing the most were still included in that. So we hopefully will be getting that out the second half of this summer is my goal. Um, Next question is the idea that babies communicate their behavior is super relevant. Adjusting the feeder's response can normalize feeding. What are your thoughts on clinicians using this information to make decisions on preterm infants? Do you plan to look more closely at the preterm infant population? Yes, we have a really big study going on right now. We have 150 babies that we follow weekly for feeds, and we are currently looking at a lot of these things and kind of a lot of these unspoken or unresearched clinical practices that we have, looking specifically at these nonverbal communication, yes, but also on like objective methods that maybe we can improve um, in our ability to know what's relevant, what needs to be addressed versus which is like the baby's about to have a bowel movement, right? Which is I actually still, if the baby's like showing you they need to stop, whatever the cause. But I think like knowing the significance of it, is this like indicating aspiration or is this eye blink indicating this is really big or that I'm human and allowed to blink my eyes? That's the tricky thing that I think we really are really excited to be looking at. I hope to have a lot of that data to you in the next 6 to 12 months. For the study about selecting flow rates, if infants were on the fastest flow rate for thin liquids, did you give them a nipple supposed to be for thickened feeds? Um, okay, so that's a great question. We didn't actually have any babies so far that were on a level 4, for example. So the question is, if a baby was like on a level 4, would you have tested them on a Y cut, which has different milk flow properties to pressure than the other ones? So great question. We have not had any in that, and if I recall off the top of my head, um, we that wouldn't even be a possibility. We only include infants in this study up to 6 months because after that, their ability to reliably get like good feeding data without distraction if things are different is really, really hard. So opted for that. Um, what role do you think the laryngochemo reflex played in the lack of aspiration in your preterm sample? Hmm. Um, I That's a good question. I guess I would probably have to chat with you over coffee, which sounds great. Let's do it more. I guess I haven't given it much thought in terms of if they aspirated or not. Um, what I will say, not related to the LCR, is that um, Sorry, my children just learned how to use Google and tell it to do things, so they're having fun turning off the lights in the room that I'm trying to give the stocking. So let's talk about if that's normal. Yeah, so I think what we know from the animal research is that bolus size is one of like the biggest indicators of aspiration. And one hypothesis I do have is that it's possible that the younger babies are less likely to aspirate because they generally have a smaller bolus size. Like looking at their boluses, I didn't measure it, but I will say it's like a lot of times it was quite small. Um, and that, as babies get more vigorous, they have larger bolus size. Maybe they would actually be at higher risk for aspiration. We didn't follow them for another swallow study, but I would be intrigued to do that. And I will close it on at what age would you expect to see bronchiectasis develop from aspiration of baby to, oh man, that's a great question that's far beyond my pay grade. So I don't know the answer to that. Um, but I think getting a good pulmonologist on our team to give like a concrete answer to that is great. I think I'm a big fan of team science, and this is a question that speaks exactly to that is, generally rarely do we really see pneumonia as an outcome. We really see more of like recurrent respiratory infections, like mild kind of things, generally speaking, for otherwise babies. So I think that's the type of stuff that like through team science, which I'm excited to do, not to kind of like volley that question, but I'm going to volley it. I don't have an answer, but it's a good question. So all of that said, thank you so much. I really appreciate you joining. Hopefully get to see you in person soon and talk about some of the cool research we have coming out.
Awesome. Dr. McGrattan, thank you so much for sharing your expertise and your research. Just a couple of housekeeping items. If you all want ashes to use for attending tonight's session, just complete the brief survey. It is in the chat and will be sent out via email. And then if you'd like a certificate of completion, just send us an email at tims-unit@tims.com. And the replay for tonight's event will be up on the TIMS website, and that will also be sent out via email. So thank you all so much for joining us, and we hope to see you soon. Bye, everybody.